Good evening again. Now we have a session on strengthening urban health systems where we have to see the challenges and opportunities. Dr. S. Sudarshini, Associate Professor, Ms. Devika Deshmukh, Dr. Manivannan, CHO, Trichy Corporation, Arul Anand, CHO, Tambaram, Dr. Dadevar, Additional Director, MOH from Pune. We welcome you, sir. Due to lack of time, I just don't want to stretch this. I think first now. So we all know that Tamil Nadu is a progressive state, particularly with respect to rural public health infrastructure, whereas urban is always a challenge. We have done a lot of exercise in improving the urban areas, in implementing various public health activities. Now we have done a lot of studies, and also people here in the panel are expected to share their experiences. I now request Dr. S. Sudarshini. Please, over to you.
So, a very good evening. So, I'm not talking on any individual capacity. I am talking on behalf of Institute of Community Medicine, Madras Medical College, and UNICEF. We together did an exercise on doing the health facility assessment of the urban health facilities. So, I would be going through what are the preliminary findings of that exercise that we did. So, this exercise was done as an, the exercise was given to us by NHM. They instructed Institute of Community Medicine to do a health facility assessment of urban primary health centers and community health centers. So when this task was given, what we did was, we took the guidelines, IPHS, can we change the slides? Yeah. So why this exercise was given? Because we know Tamil Nadu is getting more urbanized day by day, and after NUHM, most of the facilities which were existing as urban health post dispensaries and maternity centers have been reorganized to become the urban primary health centers and urban community health centers. So therefore they had different infrastructure, different manpower structure and different service delivery. So to put a different form into a different form, it's a huge challenge. So we wanted to understand what are the regular basic service availability and readiness of these urban PHCs and CHCs. We did this exercise only in 11 corporations of Tamil Nadu. We did a facility level assessment so that this could guide us on understanding what are the places where we have to do improvement. Next slide. So this tool for the health facility assessment, we took IPHS standards 2022 as the base. So from IPHS 2022, we developed a tool. And this tool went through an expert consultation in a form of 2-day workshop. The experts discussed and finalized the tools, which was then put into ODK tool. And this ODK tool was validated using NQAS assessors in 2 days in Poonamali HUD. And then this was again piloted by postgraduates from Institute of Community Medicine, which was done in 30 different facilities of Chennai Corporation. And finally, we had the tool in place. So using this tool, next slide. This tool consisted of 13 different sections, which was done using staff interview, observation and record review. Totally this tool had 3026 questions, which needs to be done in 2 complete days. Next slide. So we took 50 assessors who were national quality, NQAS assessors. We gave them 1-day training in 3 different sessions in Chennai, Madurai and Coimbatore. And we also allotted mentors for these assessors. Whenever they had doubts or queries when they did the assessment, they fall back on the mentors. And the facility assessment in these 11 corporations was done between May to July 2024. Next. So we had 11 corporations, 163 facilities done by 50 assessors. We had 2 days per facility, and 3 to 4 facilities were assessed by assessor, and we also had supervisory visits to ensure whatever data that is collected is correct. And these were the things that were assessed in day 1 and day 2. Next. So coming to the findings, the preliminary findings of whatever we did. So this is in comparison with whatever IPHS has prescribed. So of the 149 PHCs, 28.9%, close to 29% of the facilities were newly created under NUHM. And of the facilities, 149 PHCs, 25% of the facilities were already NQA certified. And similarly, close to 50% of the facilities, CHCs have been NQA certified. Next. So, I now would be listing out the key challenges or the key gaps that we can look forward to filling those gaps. So, IPHS says that for one PHC, the population norm is less than 50,000. So, when we look at here, only 1/5 of the urban PHCs cater to this population of less than 50,000. You can see there are 3 institutions which are catering to more than 1 lakh population. And with regards to the building size, IPHS dictates that the minimum building space should be close to 366.44, which is close to like 3,500 square feet. Only 1/4 of our facilities meet that. When it comes to CHC, the minimum requirement given by IPHS standard is 40,000 square feet. But the maximum size of that one of our CHC have is 20,000 square feet. So I'm not sure whether we would be able to fill this, whether we would be able to address this gap, but this is one of the gap that we have. Next slide. So this is the criterion-based complaint score that we have developed for each of these items. So we have developed the criterion-based complaint score with respect to IPHS standards for infrastructure, infection prevention and control, essential services, national programs, HR and training, labor room, essential drugs, laboratory services, immunization services, imaging diagnostics, equipments, records and register. So those in green means more than 90% of the facility have less, those in red are those which have score less than 40%. So IPHS has dictated something. More than 90% of the facilities scored less than 40%. Those are like essential drugs, imaging, diagnostics and equipments are the key areas that we need to concentrate. We can be happy about the services that we are providing, essential services that we are providing, labor room services, laboratory services, immunization services and the records and registers. Next slide. So this has been done for each facility. So we have the scoring done for each facility. So if you see, the red ones are there in equipments, essential drugs, imaging and diagnostics. I would be further breaking it down into what do we mean by when we say that there is lacunae in equipments or imaging and diagnostics. Next slide. So similarly we have it for every other facility. So these are the items that we looked at when we looked at the infrastructure. So almost close to 95%, 92% of the PHCs are in own buildings. So that is good thing for us to know. But the things that we can work on at the local level itself would be building a compound wall, because 40% of the facilities do not have compound wall, and disabled and elderly friendly access, which means having a handrail and having a lift when it is a multi-story buildings. Only 40% of the PHCs are disabled and elderly friendly, have elderly friendly access. When it comes to the sanctioned beds as per IPHS, almost 80% of the facilities have the number of beds as required by IPHS. When I say sanctioned beds, for 24/7 PHCs we require 6 beds, for CHCs we require 30 beds. So when it comes to CHCs, 64% of the CHCs only have the sanctioned beds. I'm not talking about number of beds which are available in the facility, the number of beds which have been already sanctioned. Next slide. So this is again coming to the infrastructure complaint scoring. So the things that we need to be happy about is, the operation theatre, though it is only a desirable requirement, many of the facilities, non-FRU CHCs have got operation theatres. So that is a good sign. And we have separate pharmacies and we have separate laboratories. These are all good things that we need to be happy about. Things that we need to concentrate on is lack of newborn stabilization corner, stabilization unit or newborn care corner, especially in the CHCs. Next slide. So this is again, the gaps with regard to, infrastructure. Things we have to concentrate is separate consultation room for men and women is something that is mandated by IPHS, which we lack. And similarly, separate rooms for medical officers is something that we need to, locally, if we can sit and, discuss, we may be able to find a solution for this. And the other one that we are lacking is adolescent-friendly health clinic. Yeah, adolescent-friendly health clinic. You may have to come again. So the adolescent-friendly health clinic is something that we have lacking. Next. So the other infrastructure that we lack is ICTC clinic, optometrist room, and X-ray rooms. These are something which is mandated by IPHS. Next. With regards to essential services, good thing is about we have 24/7 services, NCD clinic services, etc. Only thing that we have to concentrate on again is adolescent-friendly health clinic services. Next. These things again, these are availability of polyclinic services. Again, this is not something called as essential in IPHS standards, but most of our facilities are able to provide these polyclinic services. These are desirable services, but most of our non-FRU CHCs and PHCs are able to provide these polyclinic services, which is one of our strengths. Next. With regards to the specialist services, nutrition OPD, providing health and wellness OPD services, these things are essential, but it is not available here. Next. With regards to RCH services, things we are lacking. We are providing antenatal OPD and we are able to provide 4 antenatal clinics, etc. But the things that I have highlighted here are those which we have to concentrate on. With regards to GDM, we are able to screen almost all the women for GDM, but we are not able to provide free insulin for people with GDM. And similarly, the other thing that we are lacking is thyroid. So we are not able to provide thyroid function test, and we are not able to provide thyroid medications for women who suffer from thyroid problem. Next. With regards to intranatal and postnatal care services, the lacunae is drawback facilities. I am not sure whether we should consider this as a lacunae because most of the women would be staying close by and they won't be requiring a drawback facility. Next. With regard to family planning services, almost all the family planning, temporary methods we are able to provide. Only lacunae is PP-IUCD and PA-IUCD, whereas the facilities are able to provide interval IUCDs. With regards to vasectomy, tubectomy and laparoscopic sterilization, IPHS doesn't mandate it. It doesn't say it as an essential services. It asks us to provide only if the facility and the required manpower is there. So again, this is one of our strength. Next. So this is something we need to concentrate on. MTP services. Very few facilities provide MTP services. One of the things which is mandated by IPHS is providing medical methods of abortion. Only 16% of our PHCs and only 42% of our CHCs are providing medical methods of abortion. This is something that can be easily done, and we need to concentrate on that so that we are ensuring a continuum of care when it comes to reproductive and maternal health services. Next. So these are the programs. So what we did for composing the scope for these programs, for NTEP there are like 5 different services that have been enlisted. If they provide all the 5 services, then we gave them a full score. So in that regard, if you see NTEP, NLEP, NACP, National Mental Health Program, National Program of Non-Communicable Disease Cancer and Palliative Care is something that we need to concentrate on. So one or the other services we are not able to provide. When it comes to tuberculosis, if you see the next slide, when we come to essential drugs, anti-TB drugs availability is a problem. NLEP, again, anti-leprosy drugs availability is a problem. NACP, ICTC clinics are not present. So these are the problems that we have identified in each of these programs, provision of services through these programs. Next. So this is the essential drugs. So again, whatever IPHS has given, we have grouped them into various drug groups, and if they are able to, depending on if there are 4 drugs that are required, if they are having all 4 drugs, they would score 100%. Out of 10 drugs, if they have only 6 drugs, they would score 60%. In that angle, we are happy that all the facilities have got adrenaline, atorvastatin, contraceptives and immunizations. All the essential medicines required for providing these drugs are available. Things that we need to concentrate are anti-malarial is not available, anti-leprosy is not available in almost 141 facilities, anti-TB drugs are not available in 126 facilities. These are of concern. We need to, if we have to provide anti-EP program, then these availability of these medicines are very, very essential and critical. When it comes to diabetes mellitus, only 30% of the drugs are available because insulin was not available, and therefore with regards to anti-diabetic drugs, the score is pulled down. With regards to antihypertensives, of the various antihypertensives that have been prescribed by IPHS, 1 or 2 drugs were not available, and therefore the score was pulled down. Next. So, with regards to imaging diagnostics, X-ray is something that is mandated by IPHS. Most of our facilities don't have X-ray, and ultrasound is mandated for FRU CHCs. Again, most of our FRU CHCs don't have ultrasound. Whereas we should be happy that we have ECG and provide ECG facilities for all our patients. So regarding laboratory, HbA1c analyzer is something that has been mandated as called as essential laboratory equipment to be present in all the PHCs and CHCs, which we do not have. Probably we have to concentrate on procuring HbA1c. We also need to think about the other mechanisms, whether we can outsource or whether we can do it by hub and spoke model. Next. So this is something which is not there in IPHS, but we thought it is very important for running any healthcare facility. This is regarding the mandatory certificates and licenses. Yes. Mandatory certificate and licenses. So we don't have AERB license, spirit license. Most of our facilities are multi-storied and have lift maintenance license is not present. These are something that we need to concentrate on. Next. So shortfall rates, when DPH sir spoke on the first day, we know that there is a huge shortfall. So, the shortfall rate is more with regards to paramedical workers more than staff nurse and medical officers. This is something that we need to concentrate if we have to run a 24/7 PHC or CHC. The next slide is also about shortfall rate with regards to CHC. Medical officer shortfall rate is 74%, staff nurse shortfall rate is 95%. There is a cadre called dresser which is essential, 100% it is, we don't have dressers. Next. So, almost all the paramedical in CHCs, there is a 100% shortfall rate. Yeah, next. So, what we have tried is, we have tried to map each of the gaps, and we have tried to map it whether this can be rectified at the local level or at the local body level or at the state level, or does it require a policy intervention. So for each of the gaps, for each of the facility, this is the framework that we are going to give for each of the facilities, which will enable them to act upon the various gaps that we have listed. This is just a framework that we are showing. I am not going to discuss in detail about all of these things. Next. 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 So, this is one thing that I came across. So, it is envisaged that we may have to certify our PHCs and CHCs according to IPHS standards 2022. So, if we look at the urban PHC, the health facility assessment that we have done would guide us on taking us to get that certification, and most of the lacunae or the gaps that we have identified is something that can be done at the local level, which can push our marks to the upper end. Thank you very much. Thank you for the opportunity given.
A quick comment. Thank you, Dr. Sudashni. Most of the corporations we have surveyed medical colleges. So whether specialists to sit in the medical colleges or to come to the CHCs, that's a question. So only if you do an AED analysis, absolute essential desirable, that analysis and the policy can support. Probably because here CHOs, MHOs, doctors who worked in NHM, in the urban health mission. So all know about many of these gaps, but these are seen as spots. But if you put a lens on these spots, that is what you have done. So you have elaborated, thank you. I think we can listen from Maharashtra experience also. Madam, Please. Yeah. So in the meantime, Madam can start. Also, this laboratory has a lot of gaps, which was mentioned by Dr. Sudashni. Probably IELS can complement these gaps. So we have to make a policy in the urban area also.
Good afternoon, colleagues, respected Director Sir, respected public health officials of Tamil Nadu, respected Himanshu Bhushan Sir. I'm so happy to see you. It started with you and we'll come there. Respected colleagues and dear friends, I know this is end of the day, last sessions, and I'm not going to take much time, but we are honored to be here to share our experience of what we have done regarding the primary health care and specifically to address the urban health issues. With me is Dr. Dadevar, who is the additional MOH for Pimpri Chinchwad Municipal Corporation. The PCMC is one of the most successful corporations in the country, and he will throw more light on it. And I'm honored that UNICEF and PCMC have been able to create this framework which has a potential of scale up. Now, if you really see, your slides are not moving. Just to give you an overview, the PCMC is one of the most highly industrialized municipal corporations in the state, and rather even in the country. But in Asia, it was one of the, known as one of the largest and the richest municipal corporations. We have a population of around 25 lakhs, but within the 20, and this is as per census 2011, we know it's been more than 14 years for the last census. But what it tells us is that the population has definitely increased in the corporation. And within that, you have approximately 10% of the, almost 39% of the population that lives in slums and slum-like areas. You have around almost 1 lakh children, 0 to 5 years. And again, as I say, this data belongs to 2011. We have around 3 urban CHCs, 36 urban PHCs, 13 urban health wellness centers, and 6 Apna Davakhanas. I'm happy to say, till last year, there were only 2 health and wellness centers. Under the Ward Health Action Plan, we have been able to catalyze and push the municipal corporation to have, institute more of health and wellness clinics. Why it was a challenge and what did we do? Dr. Dadevar will focus more on that. If you have seen that, given that it's an industrialized corporation and 39% of the population living in slum and slum-like, where does it happen? Where do I place this? Yeah. Okay, next. I think that will be better. So, as I was just telling you that, why is it that if the corporation is so rich, why is it that the corporation is doing so well, which you will see, that we have gone for a Ward Health Action Plan? This, I'm just going to focus to you on and give you the snapshot of the vulnerability assessment that we carried out in PCMC and how the vulnerability assessment really brought the focus on the need for primary health care. If you see, this is the survey that we did. Next slide. And we covered around 3.62% of the entire population in this sample of the vulnerability that we carried out. It's a community-based vulnerability assessment. This is based on the NSRC tool, which was further modified and contextualized to the needs of the municipal corporation. And we find that on the 4 parameters that you see here, the social vulnerability, the residential, and the health, the data clearly points out the disparity and the vulnerability. If you look at the social vulnerability, you find that the entitlements, the social protection is definitely a challenge. Although you see that 0.56%, 56% of the 15 to 18-year-old are working population, in reality, the number is large. And this is what the data tells you, that we have around 4.9% of the children who are out of school. Similarly, for the occupational, the residential, you still have residential vulnerability, as we all know what it constitutes in the slums. And what I'm giving you is just a snapshot. There are around 100 indicators which we have looked at, and analyze, but before the government endorses, we are just giving you a snapshot of what has really come up. And as far as the health vulnerability is concerned, you do see that there is definitely a challenge, and access to private services is more. Next slide. Of the vulnerability, we find that between the residential, social, occupational, and health vulnerability, social vulnerability is a vulnerability which can be managed, which, if influence, has an impact on the occupational and health vulnerability. This is definitely an area that UNICEF and the municipal corporation in the state would like to further work on, that is, address the social vulnerability, as a result of which it will have a multiplier effect on the occupational and health vulnerability. Let's go to the next slide. So what exactly is Ward Health Action Plan? The Ward Health Action Plan is based on the National Urban Health Mission's guidelines, the recent guidelines that have come up, and including the earlier one. It is based on the Astana Declaration, so very globally validated input has gone into this. We are looking at making the Ward Health Action Plan as accessible, affordable for the slum population, and it is clearly based on 6 pillars, that is your evidence, your governance, your partnerships, basic services, community engagement. So the PHC model that we are really talking about is what the Ward Health Action Plan is based on. Now, how is it operationalized? How did we go about doing it? It's just been a year since we have implemented it. This I would really like Dr. Dadevar to come here and share with you, because it's nice to have government to government sharing on this. Dr. Dadevar, please. Thank you.
Good afternoon all. Myself, Dr. Abhay Chandra Dadevar. I am additional medical officer health, means it is similar post like corporation health officer in Tamil Nadu. Actually, we were feeling when since last year I am working as additional medical officer health, and we find that there are many guidelines are missing for urban population, as everything we are copying NRHM guidelines. Whatever in the rural area, the guidelines are same, we are applying for the urban areas. But there were many difficulties while operating these guidelines, because the urban issues are totally different. So we have introduced this Ward Health Action Plan for our corporation. Next slide. These are the few glimpses of our Ward Health Action Plan introduction meetings, workshops, UHND sessions and all. Our corporation is heading by our commissioner, who is IAS officer, and medical officer health, additional medical officer health, and other team are there. Next slide. This is the organogram of our corporation medical department. Commissioner will be the heading, commissioner is heading, and medical officer health and additional medical officer health are down the line, where we are having 1 postgraduate institute and 5 multi-speciality hospital and 36 UPSCs and almost 20 now UHWCs. Next slide. As Devika madam mentioned that our corporation is richest corporation, it is not is, but it was richest corporation in Asia. We have built such a building of health infrastructure, but we found that we are weak at foundation, that is primary care. We have a very good maternity homes, multi-speciality hospital, even tertiary care hospital, but we are lacking at the primary care centers. That is, we required actually 50 UPSCs, but we are at 29, and we require almost 175 HWCs, but we are at around 20 now. Last year, when we have tried to make a HWC, but we were not finding places for that. When the sanction, we have got the sanction of 12 HWCs from central government in 2022-23, we couldn't start a single HWC. But after introduction of ward health action plan, because in this we made some ward health committees, and these committees worked for these OPDs, and we could start almost around 20 HWC and 30 more are in queue. Next slide. These are our hospitals. Here we are reflecting the OPD. Every year the OPD patients are increasing. Almost 15 lakh OPD we do cater every year. Next slide. Almost around 90,000 admissions are there every year. Next slide. Almost 25,000 surgeries we do conduct every year. Next slide. Around 6,000 ICU admissions every year, means we are reducing the out-of-pocket expenditure of our citizens, and every year the curative services are increasing. Next slide. In 2022-23, we were at the position of, in state ranking, we were at the position of 8th or 9th. In April 23, we came up to 5th rank after introduction of this WAB, and now we are at 2nd position. In future, we will be at 1st position maybe. Next slide. It is a ranking done by state government. Now we will discuss the pillars of the Ward Health Action Plan. There are 5 pillars. In that, first, evidence building. In evidence building, we did a vulnerability assessment study and health facility assessment studies. Then in governance, we formed the city health action plan committees, then ward health action plan committees, below that institute level committees, and below that up to the area level action plan committees. These committees are formed as the corporation is a whole unit in the city, and it divided into 8 wards, A, B, C, D, E, F, G, H. In that, each ward is functioning as a sub-municipal corporation. Each ward is heading by assistant commissioner, and under the assistant commissioner we have formed the ward committees, and under the commissioner we have formed the city task force committee. In service delivery, we have made the micro mapping of the ANM. Each ANM has a micro mapping, did her micro mapping for her area. In that, there are 40 to 45 fields are there. Once she make it, she can deliver a better services, and she can reach up to the last one. In community participation, we increased our Mahila Arogya Samitis, and we have increased our ASHA recruitment, and we included the other federations and senior citizen forums also, and partnerships with the IMA, NEMA, and other these health organizations and housing federations. Next slide. With this intervention, we can reach up, we can do a better, we can result a better healthy. We can result into better and healthy city. And in last 2 years, under WAP, we did many activities. It started in the June 2022, and till August 2024, we have done many activities. This is the timeline. Next slide. There are 4 key stakeholders: government, government or our urban local body, then the medical department of local body, and communities and partners. Everyone has their own different roles. Next slide. We have achieved following things. In the vulnerability assessment study, we found the 6% out of school children. We could enroll them in schools, and renewed focus on disability, because our ASHAs, every ASHAs have many of the disabled people in their area. In administrative commitment, dedicated WAP budget 25 lakh per ward we have sanctioned, and we have got sanction for Pota clinics, where the slum population can be catered, and costed action plan for wash component. Engagement with the community in informal settlements, where we conducted the pilot community management 24/7 water supply 200 for the 200 households in the community, and we made SOPs for UHNDs, enabling the interdepartmental accountability with micro planning. We made an area level action plan and subcommittees at the facility and community level. Next. There were challenges while doing this. For evidence building, we do not have a baseline data of NCD, and we do not have a data of RTA, road traffic accident and industrial accidents. And the data, fragmented health information system. In governance, there are process intensive, as we have to get many approvals from different levels, and the non-resident A&M in rural area, the A&M stays in her area, but in urban area, A&M stays somewhere else, and she comes to that area and she serves that. It is difficult for her, so she cannot work efficiently. Public health infrastructure, which is inadequate funding and lack of skilled health workers, and urban health policies or governance and lack of intersectoral coordination. But through WAP, we can find this intersectoral coordination. In service delivery, there is a triple burden of diseases, that is communicable diseases, non-communicable diseases, and road traffic accidents, and shortage of HR, like from A&M to specialty services. And in community participation, there is a lack of social cohesiveness and partnership. There is a distrust between the private practitioner and government doctors and associations. Next. There are few testimonials. One of the assistant commissioner, that Anna Bodade, he said that as this Ward Health Action Committee forms, we all could work together and we could do better. And our frontline worker ANMs, they are saying that as the area level action plan committee, as we have formed, that is micro mapping, and this micro mapping helping them in their routine work. Next. Thank you. Take home message is, we are working for the whole of the city, all age groups, both genders and all classes, elite, slum-like and slums. Thank you.
Thank you, Ms. Devika and Dadeva, Doctor. So different perspectives, and we have to learn some initiatives from you. However, there is one question. Despite you having a new strategy, you need not answer to this question. Just it's a question from that arises in my mind. That's whether it is going to be a sustainable. Suppose if it is without funds, only depending upon the local body, and how do we expect A&M to stay, particularly in an urban area, when we are not able to keep people in even rural areas? Because probably I guess that the A&M will not be staying more than 10 kilometers from the working spot, and the mobility is also easy. So this is all questions in my mind, but anyway, it's a good thing. And one more thing is 25 lakhs per annum, supported by UNICEF.
No, sir. 25 lakhs every time. Every time, whenever he wanted to, these are the powers, means previously they were having the powers of 10 lakhs.
So I understand that once 25 lakhs is spent, another 25 lakhs
another
are
25 lakhs will be added.
Okay.
Every time.
So that is a good initiative.
This is for a new construction or anything. And 5 lakhs for small program like conducting UHNDs and all. These also, once 5 lakhs finish, next 5 lakh will be added.
Right. Okay, sir. Okay. Anyway, thank you for your excellent presentations. Now, can I hear from Dr. Manivannan and then from Dr. Arul Anand? Can we have a quick points from you?
சரி. அனுப்பிச்சிடலாம் உனக்கு. ஃபர்ஸ்ட் அவர் பேச.
Good evening, respected my director, additional director, and all my JDs and colleagues. So this is about strengthening urban immunization RCH service and Tambaram City Municipal Corporation. It's basically through service area mapping and vulnerability assessment based on enumeration of the population. Next. So it's about Tambaram City Municipal Corporation, a newly formed corporation. It was originated in 2021. It was formed by merging 5 municipalities and 5 town panchayats that were at the time. So it's now roughly around 87,000 square kilometers, and has around 2.52 households and 10 lakh population. So we have 45 notified slums and 83 unnotified, so totally 128. Well, the UPHC that's catering is we have 13 urban UPHCs and 9 health and wellness center functioning, and another 9 that's under construction. So we prone for floods and everything is there. And most important thing is another 18 more villages are to be added by January. So our population square meters will increase considerably by another 100 square kilometers, and at least by another 6 lakhs population. Next. So what is the problem we have? As you know that this was done by merging 5 municipalities and panchayats. So there's a lot of unserviced areas of the PHCs. So we have difference in PHC's population itself. Some one PHC is around 27,000 population, another PHC, urban PHC is catering to 1,45,000 population. So it's ranging from almost 4,000 to 8,000 we have around in the health sector. So what will be our new requirement as per population norms is, for the 20 UPHs we require, but only we have 13. So new 7 PHs to be established. And we need 101 UHN area, and we have only 69. So 30 more UHN area are to be established, and we have to find out where to locate them. Next. And we also have the migration like everybody else, and it's near to the Chennai. Just we are on the gateway of Chennai. We have a lot of migration problems, and growing infrastructure area is highly having. So we have that construction site happening everywhere. So we need to do a vulnerability assessment also. So it's both the occupational and health, and as well as other related vulnerability assessment we have to undertake. So whatever the population data we have is very much outdated. It's a 2011 data, and has not been though we are able to do on projections. So we are not able to extend. So we have our own problem is most of the A&M areas though are commercialized. So they do not have enough households to stay there. So their achievement is very poor. This is what when we did the minimal assessment, the commercial area was more than 90% and the households were only 10%. So they had this thing. So right in the map that I am showing is, we have 2 different, same that pink color is the same PHC area, but in between another PHC area also comes. So there's a discontinuity in the PHC area also. These are where we are able to find out in the initial mapping. Next. So what we propose to do is physical mapping and convert it into a GS mapping. So existing service area. So we wanted to see this existing service area, where are the UPHs, and found out the gaps. Then we want to do a enumeration of population, something like a vulnerability assessment using the family register plus questions on vulnerability assessment, and little bit tutored for the urban local bodies needs. So initially we started to do with the 360 enumerators, and data collection tool was a ODK app. Then the idea is to develop a monitoring dashboard along with the subsets that vulnerable population like eligible couple, RCD, NCD, then the data may be migrated to PHR, our own, and then creation of ABA card, GS monitoring of service, everything that we want to do. Then we continue at the facility gap assessment also. Next. So immediate output what we are talking about, defining the service area. So as you said that service area is not continuous, so we have so many problems, so we need to see want to fix the service area for each, and that should be based on the population norms as per the NUHM. Then evidence to support creation of new facilities so that we can go to the Government of India and ask for new facilities. So almost 7 new urban PHCs we require, and 30 UHN area we may require. And then based on the data, then we have a digitalized base population, that's a digitalized FHR that we want to do, and it will be our denominator. And based on this denominator, we can fix the enumeration target, and all targets can be fixed for the ANMs. And for micro planning, we ask for a monitoring dashboard also. So overall output, we'll be establishing a EFHR with real-time updation and effective monitoring and for visitors and migrant, improvement in identifying various vulnerable groups and service delivery, ensure service delivery in outreach areas also. Next. So far progress, we have done initial mapping has been done, and wherever the service gaps are there, we have corrected, and with the regular whatever the nearest UHN area, we have covered it, mapped to them. And so then, as far as the enumeration of population, the questionnaire we have developed, and data collection tool also we have developed. So around 114 questions are there on various items, as you can see this. Next. So these were the gaps that for each PHC we found out and corrected it at assess now. We have not done enumeration, so waiting for the population data to come for improving the service area also. Next. So these were the gaps for each PHCs. Next. Next. So we are undertaking the testing of the enumeration app. Next. So we done one TOT also we are done. Next. Thank you. Next. Let's put the next. We have some questionnaires that's suitable for ULB also. We added a lot of social economic questions that may relate to these ULBs also we added and kept. Next. Household details we collected. We collected even pet details and all. We have included the questionnaires on them. Okay. Thank you.
Good evening. I am here to talk about the challenges and opportunities pertaining to the urban health of Tamil Nadu state. Next slide. So this is the urban demography of the state. As we all know, our state is the most urbanized state in the country, and as many as 54% of the population lives in urban area. This excludes the so-called already urbanized panchayats. Some 500 or 600 odd panchayats are waiting to be declared as urban area. So roughly already 60% of the area is urban. So by 2030, it may be around 75% of the Tamil Nadu population will be urban. So this urban population is distributed across 25 city municipal corporations, 134 municipalities, and it's not 1,000, it's 490 town panchayats. And the urbanized condition in Tamil Nadu is the dispersed model of urbanization, which is unique in our country. Every state will have one or two urban pockets, and which will be called the prime city, urban city, and the urban population will be concentrated around the city. But Tamil Nadu, it's a unique dispersed model of urbanization. So the urban population is distributed throughout the state. So which warrants a statewide urban health plan to be formed immediately. Next slide. So this is the present setup in Tamil Nadu. You can see most of the government secondary and tertiary health centers are located in the urban areas. Even though every center is located in the urban area, all are overcrowded and overburdened. Parallelly, a very vibrant private sector at all levels, primary, secondary and tertiary, is present in the urban area, but it is largely unregulated or under-regulated, resulting in high out-of-pocket expenditure for particularly to the vulnerable slum population and the migrant population. In contrast to the private sector, the government primary care services are not as organized as seen in the rural areas of the state. Next slide. This is the urban primary care history. So traditionally, whenever there is a talk of public health, it is considered as rural public health ever since the 1946 Boer Committee, which stated that rural public health is the need of the hour. Subsequent to the Boer Committee, the Mudaliar Committee, or the subsequent 5-year plans, all were uniform in accepting that healthcare facilities are more in the urban areas. So all the plans, all the committees recommended more funding, more facilities in rural areas. Even the sixth 5-year plan, which was formed due to the Alma Ata Declaration, it explicitly commented that no more curative facilities should be developed in the urban areas. Our urban area is more saturated with health facilities. It was only in 1982, the first Christian committee, it understood the problem of the urban health, that there is a special group of urban poor and urban slums, and their need to be addressed. Subsequent to the Christian committee, the 1983 National Health Policy or the 2002 National Health Policy also talked about the need for revamping the urban health. But no major efforts has been made. Now and then few projects like the urban revamping schemes, the Indian population projects, of which the IPP4 largely funded the maternity homes in Tamil Nadu. So we could see only a few MCH services are concentrated in local bodies and controlled by local bodies in Tamil Nadu. Next slide. So as we all know, the National Rural Health Mission was launched in 2003, which changed the perspective of the public health in the entire country. So after the implementation of 2003, in 2008, the Government of India understood the need for a formulation of a urban health plan, and they formulated a strategy in 2008. But it took another 5 years to launch the program. In 2013 only, the National Urban Health Mission was launched to strengthen the urban health scenario. So after the launch of Urban Health Mission, there was a norms was formed. As we all know, there is an urban primary health center, there should be urban community health center, there should be field worker, ANM for 10,000 population, and ASHA for 1,000 to 2,000 population should be formed. And more focus on urban poor and urban slums is part of the framework of the NUHM. Next slide. So this is the status of NUHM in Tamil Nadu. As you can see, currently we have 140 urban primary health centers in the Greater Chennai Corporation and another 360 urban primary health centers in rest of Tamil Nadu. And recently, a new concept of urban health and wellness center were opened, and 500 were opened throughout Tamil Nadu, and another 208 are yet to be started. These were all part of the Finance Commission grants. Another 128 polyclinics were functioning in the urban areas, and also 35 RBSK teams to cater the needs of the schools. Yeah. And 39 urban PSCs were declared as urban CHCs, even though not fully functional as discussed previously. Their namesake, it was functioning as urban CHCs. And in 2015, the Director of Public Health has been designated as an administrative head of all the urban primary health centers in the rest of Tamil Nadu, while Chennai continued to function under the Greater Chennai Corporation. These numbers may look good, but when compared to the rural areas, next slide. Next slide, please. So this is the status in the rural area. You can see a very vibrant primary healthcare setup in rural areas of 1,832 rural PHCs, 424 CHCs, 385 blocks, 770 RBSK teams, and around a whopping 56,000 staff spread around 38 blocks. But still, this serves only around 50% of the population. You can see the numbers in the previous slide. The rest of the 50% is served by a very few number. Next slide. So these are the current challenges in the current challenges. All the urban primary health centers, the problem of the dual control in the rest of the Tamil Nadu, whether is fully controlled by the local body or under the which of the things should be controlled by the local body and which things should be controlled by the DPH is not yet clear. Even though the GO has been made in 2015, it was not fully enforced till now. As we also see, the Greater Chennai Corporation is still full control by the urban local body. So as we already discussed, there is a dispersed model of urbanization in Tamil Nadu, which warrants a need for a single state level technical administrative control. And also the sanctioned staff strength is also very low. If you can see the rural PSCs, there are 2 medical officers. Urban PSC, there is only 1 medical officer. There is no regular staffs. All the staffs are contractual. There is no health visitor or a SHN. Then who is going to supervise the UHN? We don't know. Then there's the male component or the health inspector component, not yet addressed. So these are the challenges in the urban framework, and all the frameworks described in the NRHM pertaining to the rural context has all been copied to the urban model, which is quite impractical to follow. The role of the sub-district hospitals or the district hospitals, which is located in the urban areas, is largely ignored, and where there is a need for, if there is really a need for developing a new CHC when there is an already fully functional sub-district hospital and a district hospital in the urban area, we have to think over. So the importance should be given to the slums and the urban poor. Already the slums are overcrowded, where we are going to find the land to build a new health facility to serve the slums and the urban poor. Parallelly, the regulating the private sector is also a major challenge. The Clinical Establishment Act is more or less a licensing act rather than a regulating act. So who is going to regulate this vibrant private sector located throughout the state? Next slide. So these are all the opportunities. The urban local bodies are heavily cash rich, and the gaps we find in the government funding of the health sector can be met out with the funds of the local body. The vibrant private sector can be robbed out through various PPP modes, as already we see in the various insurance models. So for the strengthening the urban care. And we also see in the 15th Finance Commission, huge funding has been received recently, which will continue to strengthen the infrastructure gaps in the urban primary health care. And there is a huge possibility of a holistic, promotive and preventive One Health concept, which could be replicated easily in the ULB, in all the ULBs. Next slide. So this is the biggest challenge. After implementing rural health, the Directorate of Public Health has to think, all the staff right from the top to the bottom, they think urban is not their area. So DPH should be no more a Directorate of Rural Public Health. It's a comprehensive urban health should be catered. If not DPH, who is going to improve the challenges in the urban area? So whenever an area is declared urban area, all the staffs are transferred out, and new staffs has to be appointed through contractually in the urban area. So the easiest way out is take over of all the facilities in the urban health by the Directorate of Public Health, which has a rich experience in managing the rural primary health for more than 100 years. Thank you.
Thank you, Dr. Manivannan. Manivannan, being a senior professional in our department, his perspective of challenges is very, very practical, you all know. Sorry for restricting you to short time. Similarly, Arul, he has made an excellent presentation. He has worked in the state as well as in the field level, a vast experience. Now he is doing the vulnerability assessment. Thank you. And Ms. Devika and Deva, if it is going to be a continuous success, it is something going to be a phenomenal one, which can be practiced everywhere. And excellent presentation by Dr. Sudarshini. I was also a part of that survey. Now, putting a big lens and seeing a lot of loopholes and needing a policy decision at a greatest level in an urban area, that is the vision of that survey. Probably it will open a Pandora box, which has to be decided at the policy level, many, many things. So now here we can see a lot of VHNs sitting in the audience who is doing backbone of our public health department. So we see a lot of scope, and we are doing, our director is doing a rationalization of HR and infrastructure. That is what Arul was also mentioned about the number of, Manivannan also had mentioned the requirement of more number of urban primary health center, more number of field staff. That is lacking, and we are voicing out for many number of years, and it is yet to be heeded. So this is for the Maharashtra team and Pune team, because this Tamil Nadu is also lagging behind many things in urban area, but we always hopefully foresee a huge positive stride in this. Thank you. Thank you all for the excellent presentations. Thank you.
Thank you, sir. Now we request our additional PhD, sir, to felicitate our panelists. First, to Dr. Manivannan, CHO, Trichy Corporation. To Devika, Deshmukh, Program Specialist for Urban UNICEF. To Dr. Tadevar, Additional Medical Officer of Health, PCMC. To Dr. Sudarshini, Associate Professor, ICM, MMC, Chennai. To Dr. Arul Anandam, CHO in charge, Tambaram Corporation. Thank you, sir, ma'am.